The second fighter, you have a boxer, you know. The second fighter is Dr. Osama Kentab. He's a senior pediatric emergency in National Guard Hospital, Riyadh. And also he's the chairman of the cardiopulmonary resuscitation committee. He's American-Canadian Board of Pediatric Emergency, one of the senior people. And he will talk about no.
I'm not sure if no still exists. Okay. So a compelling fight really from Ammar, and I'm really interested to see. I don't think the no is really a clear answer, but I don't have anything to declare. I thought we will have two to fight for one, but apparently we are presenting the same thing. So to start with, please concentrate on the watch. The watch is shaking. Your eyes are dazzling. And after this big lunch, you're going to continue being dazzled. So what we're going to do, we're going to make you more dazzled. So please look closely. Exactly. Now we're trying to find out if you are migrainous. So we'll see how many of you people are going to become migrainous now. Now, remember the word. I will say no. We haven't learned really to say no in our life. So to me, this is a very important word to learn. So I will always continue saying no until really I'm convinced to do something which is really yes. Migraine headaches are really something that is very common. Presentations are really sometimes vague to us, especially in the pediatric population. We find a lot of patients presenting with different symptomatology that we are really in trouble with, and they turn out to be really migrainous. Benadryl was synthesized in February 1944. It's a competition with histamine for the site of physiologic response, and that's why they use it for allergies. Now, people will say, etiology, maybe there is an allergic component. There is no proof. Maybe it's really vascular. At this point in time, there is no proof. So the etiology is obscured, and it's not really very clear. So it's very poorly understood how the pathogenesis of this occurs. So the question is as to whether the effectiveness of these drugs is due to their antihistaminic properties or to their well-known sedative effect. So I'll just compare this to your child when you're traveling on the airplane. What do you give him before he travels? Benadryl. How really control him in the flight? Benadryl. So it seems that Benadryl is being used really well for this thing. So I don't think really at this point in time that Benadryl has any effect on the really workup on headaches. The oldest review that I have found is really in 1957, where Samuel Rosner came and said, my work with Benadryl has shown me that it is of definite value in the aforementioned conditions when used with Novocaine. So this drug has never been used alone. And that's why people look at the use of Benadryl in conjunction with another medication. So it cannot be used alone for just simply the treatment of headaches. So in short, again, no evidence. Now, in the first two randomized double trials with Friedman, he says there is no significant difference between metoclopramide alone and metoclopramide plus diphenhydramine in the management. Again, to repeat it again in 2012, no difference between diphenhydramine and placebo in reducing akathisia itself. So when Ammar was started to talk about akathisia, I said, are we treating akathisia or are we treating migraine? So it ended up that akathisia can be treated with Benadryl maybe, but not migraine. Now, the most recent randomized double-blind trial of metoclopramide versus metoclopramide plus diphenhydramine also finds no significant difference in sustained relief at 48 hours or in reduction of pain by pain scale. That tells us that Benadryl really has nothing to do with this issue. Now, there is another randomized controlled trial, retrospective selection, and the neurology issue was published. It shows, again, when comparing pre-protocol head pain levels to third dose protocol head pain levels, the paired sample t-test showed a statistically significant decrease following administration of diphenhydramine. Diphenhydramine may be efficacious. In some cases of refractory daily chronic headache, the value of diphenhydramine in the treatment of head pain warrants further investigation. This is the only study that I found that it says that diphenhydramine may really help. So it doesn't really get supported very much. It doesn't have really a major evidence. So diphenhydramine may be useful in the treatment of neuropathic and nociceptive pain that has failed to respond to treatment with opioid and adjunct analgesics. And where? In patients with cancer, not really with patients with headache. Now, Benadryl as an adjunct in migraine treatment is very well known, right? But because these side effects are treated with diphenhydramine, many clinicians administer a small dose of diphenhydramine whenever they administer these medications that are the treatments for migraine. So it's just an adjunct treatment that may not really help a lot. And it goes on again. So the correct answer for the question, should I give Benadryl with the treatment for patients with migraine or not? And the answer is clear. There's no evidence to it. So I think we should really refrain from doing it unless our child is traveling on the airplane. And that's a different story. There is a comparison between acute treatment regimens for migraine in the emergency department, and they resulted showing that diphenhydramine with dopamine antagonist was associated with 27% increase odds of an ED revisit compared to dopamine antagonist alone. And that's what Ammar has alluded to in the study. So diphenhydramine use is associated with increased rates of return. And again, should I prescribe something that will bring the patient back to me? I don't want to see the patient in the first place. So why should I give him something to bring him back? So that's an additional value, right? So I think I have 1 minute more remaining, so let me jump to conclusion here. It does not improve migraine outcomes. There's no reason to co-administer it intravenous diphenhydramine with metoclopramide routinely for ED patients with acute migraine. So even that level is really, in a randomized controlled trial, did not show that diphenhydramine really works. So the answer for the question is no. We're not going to use it. So I'll stop here. So where do we stand? On the ground, definitely, of course. No clear evidence so far for the use of using it alone. So thank you very much.
Thank you. Actually, we have no and no, huh? Where the yes? There is no and no. Okay. How they are guys convincing? Who say Benadryl gonna benefit in migraine? Say yes. No. Good. Yeah, it's good. Good. Thank you. Any question? We have 1 minute only for questions. There is no yes, there is no, yeah. That means it is. Absolutely.